we've three speakers, Professor Brian Lawlor, who's Deputy Executive Director of the Global Brain Health Institute, Professor Michael Rowan from Neuropharmacology, School of Medicine, Trinity College Dublin, and Seán Dónal O'Shea, who's a former family carer, is also a Dementia Adviser with the Alzheimer Society of Ireland, and has also completed some research in the area of céilí dance for people living with dementia and carers. So you'll hear from the three speakers. They'll talk for about 15 minutes each, and then we'll go to a Q&A session. I will try and address everybody's questions. Sometimes we get a lot of questions on these types of webinars, so we only have 10 minutes at the end, so we'll do our best to answer all the questions. So I'll hand you over to our first speaker. So Professor Brian Lawlor, who's Deputy Executive Director in the Global Brain Health Institute, Trinity College Dublin. Brian was also previously a consultant psychiatrist in St James's Hospital for a number of years, and was also instrumental in establishing this research network, Dementia Research Network Ireland, and was chair of the network for a number of years. And he's been very active. I'm sure a lot of you know Brian, or have heard him speaking before. He's been very active in Alzheimer's disease research for a number of years. So I'll hand over to you, Brian.
Thanks very much, Carol. And it's a great pleasure to be here this morning, and delighted to see Mike Rowan and Seán Dónal, and looking forward to having a conversation with you at the end. So I'm here to talk about some of the secondary analysis from NILVAD, the clinical trial that I was involved in, and the implications for clinical practice and research in Alzheimer's disease. I'm presenting this on behalf of the NILVAD study group, and I want to express special thanks to Adam Dyer, Claire Murphy, and Sean Kennelly, who did a lot of the heavy lifting in terms of the analysis. So what was NILVAD? NILVAD was the first large-scale definitive intervention trial with a medication called nilvadipine, which is a blood pressure lowering medication to test for a disease-modifying effect in people with Alzheimer's disease. Now, why was nilvadipine chosen? Well, in addition to lowering blood pressure, which may have benefit for people with dementia, nilvadipine also lowers A-beta-42 in animal models of Alzheimer's disease. So the design of the original NILVAD trial was as follows. It was a phase 3 double-blind placebo-controlled trial. We recruited 511 people with mild to moderate Alzheimer's disease with a minimum state examination between 12 and 26. They received either 8 milligrams of nilvadipine or placebo over a treatment period of 18 months. And our primary outcome measures were the ADAS-Cog and a CDR sum of boxes, and the secondary outcome measure was the disability assessment for dementia. So ADAS-Cog measures cognition, CDR sum of boxes looks at the stage of dementia, and the disability assessment of dementia looks at the level of functional impairment. Well, unfortunately, I can report that the study was negative. It was well executed, on budget and on time, but nilvadipine did not show any benefit over placebo on any of the outcome measures. However, there was a lot of secondary data gathered, and the question was whether the secondary data from NILVAD could inform us about potentially modifiable factors that could be addressed to stabilize the course of Alzheimer's disease. And that's really what I'm going to talk to you about. So I think it's important to look at the potential to stabilize trajectories in people with dementia. And taking a brain health approach is about getting the most out of your brain, protecting your brain, even if you have dementia. And taking this type of approach, I think, has the potential to stabilize trajectories in a number of different ways. First of all, by treating and preventing delirium in people who have dementia, by decreasing adverse events and unscheduled hospitalizations, because hospitalization can result in a deterioration for people with dementia. Avoiding medications that adversely affect cognition certainly can have benefits for people with dementia. And finally, addressing risk factors such as hypertension, orthostatic hypotension, atrial fibrillation can stabilize trajectories. I really want to focus on number 2 and number 3, adverse events, unscheduled hospitalizations, particularly related to medication use, and avoiding medications that can adversely affect cognition. So we were lucky in the NILVAD trial in terms of being able to look very carefully and very intentionally at medication use. So we did a detailed medication history from patients and caregivers, and all of the medications were documented, as were the occurrence of adverse events and serious adverse events like hospitalizations or deaths, unscheduled hospitalizations, and unscheduled GP visits. The drugs were coded based on their anatomic chemical classification, and we also measured the anticholinergic, used the anticholinergic burden scale to get a sense of whether drugs had anticholinergic potential or not. And then with regard to whether medications were potentially inappropriate, we used the version 2 of the stop-start criteria to look at that. So the research question was whether anticholinergic burden or long-term antipsychotic use, benzodiazepine use, or potentially inappropriate medication could increase adverse events and affect disease course in people with Alzheimer's disease in the NILVAD trial. Now, just to tell you a little bit of the background of the cholinergic hypothesis, and I'm sure many of you are aware of this, because this hypothesis led to the development of cholinesterase inhibitors in the mid-80s. We know that anticholinergic drugs or agents such as scopolamine impairs memory function. We also know that procholinergic drugs, cholinesterase inhibitors like physostigmine, originally given intravenously, could enhance memory function. We also know that in the brains of people with Alzheimer's disease that there's a decrease in presynaptic choline acetyltransferase, and this correlates with the degree of cognitive impairment, and also the nucleus basalis of Minard, which is a cholinergic nucleus located in the brainstem, is very much affected in Alzheimer's disease. So all of this points to a cholinergic deficit in people with Alzheimer's disease and led to the successful implementation of the cholinesterase inhibitors in the mid-80s. However, there are many drugs out there that are prescribed by clinicians, but also over the counter, that can block the cholinergic system, that can cause impairment. Antihistamines, drugs used for anxiety, drugs used for bladder instability, drugs used for stomach and GI tract upset, insomnia, motion sickness, many psychotropics have anticholinergic potential. Drugs used for movement disorder can have anticholinergic potential. So there are many drugs out there prescribed for a variety of reasons can impair the cholinergic system. Of course, given the cholinergic hypothesis of Alzheimer's disease, if people with dementia with Alzheimer's disease are receiving drugs that have high anticholinergic potential, this could cause increased confusion or could accelerate their disease course. So what do we know about anticholinergic burden in people with Alzheimer's disease and dementia? Well, we know that anticholinergic burden increases the risk of people developing mild cognitive impairment and declining from a cognitive point of view. And this is particularly true if they're ApoE4 positive or if they have an Alzheimer's signature in terms of the CSF biomarkers. We also know that the anticholinergic burden dose-dependently increases the risk of people developing Alzheimer's disease over a period of 9 to 10 years. So essentially, having a high anticholinergic burden or putting anticholinergic drugs into the mix is almost a stress test for development of Alzheimer's disease. Interestingly, there have been no studies in mild to moderate Alzheimer's disease, as is in the NILVAD trial. So what do we find with regard to anticholinergic burden in NILVAD? Well, we found that over a quarter of people in the trial were prescribed a potential or definite anticholinergic drug. We found that higher anticholinergic burden is associated with more rapid progression on the functional scale, but not on the cognitive or stage scales. We also found that those who are ApoE4 positive with high anticholinergic burden were more likely to progress more rapidly. Now, moving to antipsychotic drug use and progression in Alzheimer's disease, we know that antipsychotic drugs are associated with accelerated cognitive decline. But there have been few studies in community dwelling people with Alzheimer's disease and those with mild to moderate dementia. Most of the antipsychotic studies looking at accelerated cognitive decline have been in late-stage dementia, late-stage Alzheimer's disease, and people in nursing homes. So in NILVAD, about 54 people were on long-term antipsychotics compared to 455 people who were not on long-term antipsychotics. And as you'd expect, those on long-term antipsychotics were those who are more severely affected. They had a higher degree of cognitive impairment at baseline. So what do we find with regard to rate of progression? First of all, we found about 12% were on long-term antipsychotic, and that there was accelerated decline in those individuals on the long-term antipsychotics at 12 months and 18 months. Again, if you're an ApoE4 carrier, you're at a greater risk of progression. Now, moving to polypharmacy and potentially inappropriate medication use in NILVAD, polypharmacy where people are receiving more than 5 drugs, this increases the risk of people getting potentially inappropriate medication use and drug-drug interactions. And many potentially inappropriate medications can have cognitive impairing effects. And very importantly, we know that prolonged polypharmacy may increase the risk of people developing dementia over time. So what do we find with regard to potentially inappropriate medication use? Over half people with dementia in NILVAD were prescribed a potentially inappropriate medication. About a third were prescribed 2 or more potentially inappropriate medications. The most common potentially inappropriate medications were benzodiazepines and also SSRIs. And the potentially inappropriate medications were associated with increased adverse events, serious adverse events, and scheduled hospitalizations and unscheduled GP visits. There was no effect on disease progression. What about benzodiazepines and adverse events? Well, the benzodiazepines were one of the most commonly prescribed potentially inappropriate medication. About 14% of people in NILVAD were on benzodiazepines. They were not associated with greater cognitive decline. However, they were associated with increased adverse events like delirium and falls. And as you could imagine, delirium and falls result in people ending up in hospital, and over time would be associated with a more rapid trajectory. So in summary, drugs with high anticholinergic burden, antipsychotics, and potentially inappropriate medication affect disease progression or increase adverse events that can accelerate trajectories. Interestingly, and this is consistent with the literature, those who are ApoE4 carriers would appear to be at increased risk of progression if they had a high anticholinergic burden or were on antipsychotics for a long period of time. So what are the implications for clinical practice? First of all, and most importantly, we need to carry out regular medication reviews and deprescribe as much as possible. This isn't happening, I believe, on a regular basis, and we need to introduce this type of practice. We need to reduce and avoid drugs with high anticholinergic burden. We need to think about the drugs that we use, particularly in people with Alzheimer's disease who have a vulnerable brain. We need to avoid long-term antipsychotic use and benzodiazepines as much as possible in people with Alzheimer's disease. But I think very importantly, and I think this is a very positive message coming from the secondary analysis of NILVAD, there are opportunities to stabilize trajectories and improve outcomes for people with Alzheimer's disease by addressing concomitant medication use. So I'll be happy to take any questions at the end, and I'll just hand back now to Carol.
Thanks very much, Brian. That was a very interesting presentation. So we've no questions coming through at the moment, but we may well get some at the end. So we'll now go over to our next speaker, who's Professor Michael Rowan, who's Professor of Neuropharmacology in the Department of Pharmacology and Therapeutics, School of Medicine in Trinity College Dublin. And Michael is going to talk about potential therapeutics in early Alzheimer's disease. So over to you, Michael.
Thank you, Carol, for organising the meeting and including us on the agenda. For many years now, our research group in Trinity College has been investigating preclinical animal models of Alzheimer's disease, in particular focusing on ways of tackling the very early stages of the disease before dementia takes hold. Have you got full view, Fisher?
That's perfect, Michael. Yep, we can see that.
Good. So first of all, I'll just give a brief overview of what I'm going to say in the talk. And first of all, I'll emphasize why we're looking at early stages of dementia, because later stages are associated, obviously, Alzheimer's disease, like a lot of other neurodegenerative diseases, cause the cell death. And it's quite difficult to obviously intervene at that stage. But prior to that, and even during the process of cell death, synapses deteriorate. And those are the main link with the clinical features of dementia as dementia takes hold. So two main proteins are involved in Alzheimer's disease, amyloid beta protein and tau protein. And to be actually diagnosed with Alzheimer's disease, you have to have certain deposits of these in what are called plaques and tangles, respectively. And the form of the amyloid and tau in these tangles and plaques is what's called fibrillar. So we've been investigating the effects of these proteins in an animal model that I'll describe briefly later to try and figure out what's going down at the synapses. So we've been investigating in particular the non-fibrillar forms and found that they're actually more disruptive to what we call plasticity at these synapses. And we've included not only what we call synthetic proteins, but also proteins that are extracted from the brains of patients who died and characterized their effects in terms of how they disrupt the plasticity at these synapses in the living brain of rats. So how do they do this at a cellular level? Well, we find that they actually bind to a particular site which we have characterized as a toxicity mediator. And this is another protein, cellular prion protein, which you may have heard in the context of prionopathies like Creutzfeldt-Jakob disease. But in this case, it seems that other proteins like amyloid beta protein and tau may mediate their disruption of synaptic function by binding to this site. And we think that by targeting these different, what we call rogue forms of the amyloid and tau, and also by targeting the cellular prion protein, we may have new ways of tackling early Alzheimer's disease. Why do we want to focus on early Alzheimer's disease? Well, this is an attempt to give a kind of a trajectory of the disease over several years. So somebody may have no symptoms in their 50s or 60s, but 30 years down the line, they will start to show signs of clinical dementia. And we believe that it's much more important to try and target the very early stages if you're trying to modify the disease at its kind of most tractable form, and maybe even perhaps help prevent the disease. But little is known really about this early stage in terms of what's really going on in people. And we know from post-mortem brains that there are lots of things going on in the fully demented patient. So this is to show two nerve cells in red here in a vulnerable region of a brain of a person who died of Alzheimer's disease. And the amyloid beta is deposited in these clumps shown in blue here, which is a plaque, and the tau is deposited in these tangles, which is shown in green here. But probably more important from the point of view of relating to dementia is what's going on down at the junction. So this is an extension from one cell to the next. The connections here are lost in the Alzheimer's disease brain, and associated with that are other forms of amyloid beta and possibly tau that may be really the main players. So we've been looking at how these different players may affect each other. So there are lots of hypotheses, what causes what. The original ideas believed that amyloid beta was the main cause in all forms of Alzheimer's disease. And this is possibly true in certain familial forms of the disease, where there's a dominantly inherited mutation of a protein that regulates or actually is the precursor protein of amyloid beta protein. And that eventually, over several years, causes tau disruption and disruption of synapses and eventually cell death. So that's what I might call the classical view of the amyloid cascade hypothesis. But more and more, we realize that in what we might call more less familial forms, but associated maybe with aging, there are lots of things going on in the aging brain that may kick the process of Alzheimer's disease or accelerate it and affect the amyloid beta protein and the tau protein. So you heard mention of vascular problems that are potentially risk factors that you can modify early on, like modifying blood pressure and other cardiovascular interventions that have been shown to be very helpful in early Alzheimer's disease. And it's likely that the clearance and handling of amyloid beta protein and tau, especially when it adopts certain conformations, may be altered by the brain circulation. And pro-inflammatory systems may also drive this. So you heard maybe people going into hospital for infections, etc. So it's a complex interaction between all these different causes, but you need the amyloid beta protein and the tau protein to be diagnosed with Alzheimer's disease. And they certainly are critical for the synapse loss as well as all these other factors. So we know that proteins in their natural shapes are kind of very soluble in solutions, for example, inside the cell where they're actually initially produced, or outside the cell when sometimes they're released. But gradually over time in Alzheimer's disease, obviously you get the formation of what we call these fibrils and plaques and tangles of amyloid beta and tau. But there may be other forms that are possibly more disruptive to synaptic function. And these are protein aggregates of different shapes that we can target maybe with different antibodies that are shape recognizing antibodies. And apart from the size of the aggregate increasing, the stickiness also increases. And these forms of amyloid may be much more sticky to various sites in the brain that they shouldn't be sticking to cause damage to synapses. So we've been looking at one particular aspect of synaptic function called plasticity of synapses. And this was discovered by Bliss and Loma in the 60s, but it took them about 7 years to publish their work at the time. And they found that when you apply certain training protocols to synapses, you can strengthen them. And this was called long-term potentiation. Subsequently, other functional changes like weakening of synapses or long-term depression were discovered. And associated with these functional changes, there are structural changes often that can be detected. And this may be related to the loss of synapses in late onset Alzheimer's disease. So in our animal model, we inject various materials, amyloid beta and tau, and potential drug interventions into the brain. And we record with wires in the anesthetized animal the activity of the synapses. And we can measure the strength of the synapses and train them by using different patterns of stimulation. As I mentioned, apart from injecting synthetic proteins, we can also inject fractions of brain from patients who have died from Alzheimer's disease using post-mortem cortical samples. And this work was a part of a collaboration with Dominic Walsh's lab. So many years ago, we showed that in control brain, the application of what we call high frequency firing causes a long-lasting increase in the strength of synaptic transmission. So there's about a 50% increase here. But if we had pre-treated with the amyloid beta protein, the initial facilitation may be okay, but then it decays over hours. And over many years and many experiments, we found that we could target these different aggregates and found that the fibrils were relatively inert, but by using specific antibodies, we could prevent the disruptive effects of soluble aggregates. So we believe that the most disruptive form of the amyloid beta protein in terms of synaptic plasticity anyway is through disrupting through the small aggregates. And in 2009, Stephen Strittmatter in Yale University reported that amyloid beta protein, when aggregated, actually binds extremely tightly to one particular site that I mentioned already, the cellular prion protein. So this protein is an extracellular protein. It's bound to the membrane, but dangles this little bit here that the amyloid beta, when it aggregates, finds very attractive. And we wondered, like Strittmatter, whether this mediated the disruption of synapses in our system. And we've carried out several experiments, but this just gives you an example using the Alzheimer's disease brain amyloid. So we inject this material, and just like the synthetic amyloid, it causes a disruption of the plasticity. But if we had pre-treated with this antibody, which is an antibody to cellular prion protein, and has been humanized by our collaborator, John Collinge, we actually found that it prevented the disruption of plasticity. So this is consistent with Strittmatter's proposal that the cellular prion protein is the actual cellular mediator, or part of the story anyway, in relation to why amyloid beta in certain aggregation states causes disruption of plasticity. We moved on then to tau, obviously, because it's extremely important in pathology of Alzheimer's disease. And just like amyloid beta protein, it exists in these different aggregate forms. Apart from the starting material which is produced physiologically and binds to microtubules, you get, if there's misprocessing or poor clearance, the amyloid starts to aggregate into these filaments and eventually forms tangles. So we started by looking at synthetic tau assemblies, including the monomers and the fibrils, and found that the starting material, or the natural amyloid or tau protein, didn't disrupt plasticity, whereas, and the fibrils didn't, but these small aggregates of tau actually did disrupt plasticity. So again, similar to the amyloid story, tau assemblies, which are soluble, are actually very potent disruptors of brain plasticity, whereas the fibrils are not so active. So we wondered if this was mediated through the same cellular target that mediates the amyloid beta aggregate effects. And sure enough, when we used an antibody that targets the cellular prion protein and pre-treated the animals with this, and then injected a dose of an Alzheimer's disease brain tau that normally, in the absence or with the control antibody, causes very strong inhibition of this plasticity, the antibody to cellular prion protein prevented that. So the picture we're trying to create is that the smaller aggregates of amyloid beta protein, not the fibrils, similarly of tau, are actually the disruptive ones. And they bind to this extracellular part of cellular prion protein that then somehow disrupts plasticity. And we know that glutamate is the main transmitter at these synapses. It causes excitation through acting through glutamate receptors or target sites. And it's now thought that when tau or A beta bind to this cellular prion protein, they disrupt the receptors in the membrane, and that somehow disrupts the plasticity. It doesn't exclude the possibility that amyloid beta and tau have multiple other actions. For example, we know that they can alter, for example, sensitivity to inflammatory processes and also can alter glutamate. But we would argue that this is one of the core steps in mediating synaptic dysfunction early in the disease. Because they share this mechanism, we thought that maybe it'd be interesting to see if tau and A beta interact. So we used very low doses of the soluble aggregates of tau and A beta that on their own didn't affect controlled plasticity. But when used in combination, we found that the plasticity was strongly inhibited, which indicates that they're at least interacting in an additive way, if not in a supra-additive way. So to conclude, I hope you're convinced now that we have good evidence that soluble assemblies of these proteins are very potent disruptors of plasticity in live rats at the synapses, whereas the fibrils are relatively inactive, and that we have evidence that the amyloid and tau, that as these rogue forms, are actually acting through a cellular prion protein. And finally, just to conclude, we think that targeting these what we call rogue forms of the amyloid and tau, and also the cellular prion protein, would actually be a benefit, especially in combination. It's a bit like what's used in the therapy for cancer, that just targeting one thing may not be sufficient to get a really have a knockout blow in the disease process. Thank you.
Thank you very much, Michael. That was a really interesting talk there. I know I'm certainly going to be listening back to that because there's a lot in it. So, but really, really interesting information there. Thank you. So we're now going to move on to our final speaker, who's Seán Dónal O'Shea. And many of you might have heard Seán Dónal talk before at events or might have met him in person. And Seán is a dementia advisor with the Alzheimer Society of Ireland. He's also a former carer for his mother who had Alzheimer's disease, young onset Alzheimer's disease. And he's also just completed a master's on a very interesting topic looking at adaptive céilí Irish dance for people living with dementia and carers. So he's wearing many hats this morning. So looking forward to an interesting session with you, Seán Dónal. Over to you.
Thanks a million, Carol, and thanks for the opportunity to present today. As Carol was saying, firstly, I just speak about my personal experience of caring for my mother, Debbie, who lived with early onset dementia, and then I will briefly touch on my role as a dementia advisor, and then I'll give a brief presentation on my research. So my first experience of dementia was when my mother, Debbie, got diagnosed with early onset dementia, and she was 50 years of age. At the time, I was a block layer, living at home with my mother and father, and I have a brother living in New York. So I suppose in hindsight, like when I speak to most carers, you know, it was very evident that there was something that wasn't quite right. And this was prior to the diagnosis. Mom worked in the local NCT centre only about 10 miles away, and it was the signs that were there, you know, it was 9 o'clock start, and she might, you know, take a 15-minute drive. She'd leave at 7 o'clock just so that she wouldn't need cars on the road. Coping mechanisms that my mother had in place. You know, when she'd get to work, she'd walk uptown for lunch. She wouldn't drive uptown. Small little things that looking back in hindsight were there, you know. An extremely intelligent lady. My mother, she had so many coping mechanisms. I know if you could ask her 100 questions and she would have 3 answers that would perfectly answer those questions, you know. So she hit it very well, and I'm very sure that my mother knew that she had dementia and Alzheimer's disease before any of us did. And like I said, I was a block layer, but I got hurt at work. I put out my back, and I suppose every cloud has a silver lining. It gave me the opportunity to, after Mom got diagnosed, to be her full-time carer at home. And in fairness, we had great support from family. You know, there was never not an option to have help from family around. But I suppose I quickly realized as a family carer, you know, that I nearly wanted to do it all myself, and that I was afraid to ask for help, or that I wouldn't ask for help as well. And I became quite aware, and alarmingly aware, of the lack of supports and services for somebody with not only dementia or Alzheimer's disease, but younger onset dementia, living in a rural area in South Kerry. You know, there was nothing really, you know, to be honest, and the services that were there weren't appropriate for my mother. And I mean this to the greatest respect of the services that are there. A lot of them were aimed at people in their 80s, 70s, 80s, 90s. My mother was in her 50s, early 50s, and she was often younger than a lot of their staff. And a lot of my mother went to a daycare centre in the local area, Drummond, and they facilitated so well to my mother's needs. You know, it was really person-centred, and Mom went over there assisting rather than being assisted, you know. But I suppose when we came looking for home help as my mother's dementia progressed, that's where a lot of challenges were. A lot of the home help was task orientated. It was, my mom needed nearly to be at a stage where she would either need to be assisted in a hoist or have a pad change, and nothing really prior to that. And we got assistance from the home help and the Alzheimer Society of Ireland, which would be forever grateful. You know, they were lifesavers, to be quite honest. Me as a carer prior to that, I used to get out twice in the day. It used to be prior to my mother getting up in the morning and after Mom going to bed. And like I said, I had options, but I was very reluctant to use them. For myself as a carer, a lot of the feelings that I would have experienced were very, you know, extreme feelings of, you know, the loss of the relationship that I had with my mother. You know, the change of roles, where like I depended on my mother so much, I suppose, and I'm laughing when I think about it. I remember going to the dentist when I was 18 or 19, and my mother still coming with me at that time, you know. So that was the kind of relationship that I had with my mom. And then, you know, became a carer overnight, realistically, and I didn't choose to become a carer. It was something that I became. It's something that I'm delighted that I did, and I had, you know, I had the opportunity to do, and I look back at it and fond memories. But while I became very patient in the role of a carer, it wasn't always that way. I used to get quite angry and frustrated, and I used to experience something called, what I call a carer's guilt. You know, as Mom's dementia progressed, you know, answering the same questions quite often, maybe 100 times in a day. When it came to feeding Mom, you know, and maybe struggling with feeding mom, and I'd be quite honest, I'd often say, why me, in a selfish way, or why mom, and I'd often walk out of the room angry, and it would be later on that night when I'd be down in bed, where there's nobody around, and I'd be crying. I'd be quite upset with myself because of the way I acted, or of my feelings, and it was the guilt of feeling angry earlier on in the day, for my mother, who needed my help, and I was giving her help, but it was my feelings that I was struggling with. But something that I came to realize was that I had to own those feelings, and they are natural feelings. And when I'm speaking to family carers now, they are absolutely natural feelings of the care role. I was stressed. I was emotionally, I suppose, vulnerable as well, because watching my mother slowly lose my mother in front of me, which was extremely upsetting. But like I said, the family support was excellent. And one of the best things that I did was to be able to reach out and ask for support and accept support. And again, the Alzheimer Society of Ireland and the home help were amazing in that. One thing I suppose that I did, and I bottled up a lot of feelings, and sometimes the bedroom, down in my bedroom at night when everybody was asleep, was my escape, and I'd release a lot of them, and I quite open, I'm open about now that I would cry a lot, and I have, think too far into the future, maybe overthink things, and I'd always put on a brave face then, when people would call around, and it was a coping mechanism. I suppose it served me right. It served me well. But my mother is an extremely inspiring person. She's since passed away, but she didn't die from dementia. She lived with it, and she inspired me to maybe educate myself further on in the area of dementia care. And that's, I got lucky enough that I was able to do that, and I was lucky enough to do an applied social studies and social care in Limerick Institute of Technology, and my thesis focused on those caring for people with early onset dementia, and I shared that experience with my mother, and I know when I passed my exams, she was extremely happy, and I think as many carers will learn, mom was not non-verbal at the time, but there was a turn in the eye, there was a moved lip where I knew she was, as I say, dancing inside, because one thing that myself and my mother, I suppose, did together was dance. My mother was an Irish dancing teacher, something that I never learned. She used to come down to our primary school teaching dancing, and I was half embarrassed, and I wouldn't learn it. But it was dance. We danced around our sitting room until our legs hurt, and it really benefited both of us so much. We laughed and we cried. Some songs and some tunes, brought back so many memories from my mother. My mother was born in Boston, moved to Ireland when she was approximately 18 years of age, and there were some songs that made my mother cry, but they were real emotions, real feelings, and I quickly realized the importance of dancing and dementia, and it inspired me to make a change, and I was lucky enough to have the opportunity to do my master's in research in Limerick Institute of Technology, and I will touch on that now very shortly. But again, I would find myself very lucky. I have recently taken up the position as a Dementia Adviser with the Alzheimer Society of Ireland, and this role is funded through the HSE, and that gives me an opportunity to work with people living with dementia and their families, and enabling the person living with dementia, to live as the quality of life that they are so much worthy of. The person living with dementia, in my opinion, is the most important person, and the carers, and in my role as a dementia advisor, I link in daily and have a great relationship with public health nurses, doctors, nurses, occupational therapists, speech and language therapists, psychiatric later life, geriatricians, every walk of life. And it's the ultimate aim is to provide the best quality of life and enable the person living with dementia and the carers to the best quality of life that they truly deserve. I'll just share now my research on you on dementia. So I'll just make sure that you can, and Carol, you might tell me if you can see this.
Yeah, that's.
Is that it?
Yep, that looks perfect.
So I will just give you a brief overview, and today I won't be able to capture everything, you know, that we did, or that was done in the research, but it is entitled "Some Dance to Remember: Exploring the Psychosocial Effects of the Introduction of an Adaptive Irish céilí Dance Group Activity with People Living with Dementia and Their Carers." My principal supervisor for this was Jennifer Moore-Stritch, Limerick Institute of Technology, now to us, and co-supervisor was Carmel McKenna of Munster Dance Academy, and the two of those people I'll be forever indebted for their support and encouragement throughout this research. So an overview of the research took place in a daycare service in the Midwest of Ireland. It consisted of 25 semi-structured interviews, and it was conducted over a 9-week period. 10 of these interviews were with participants living with dementia, and 15 were with care staff participants. This research focused on the lived experience of participants, so a qualitative approach was used, and all interviews were transcribed, and data was analysed using thematic analysis. And in those interviews, the person living with dementia was interviewed before the first dance activity and after the last dance activity, and care staff participants were the same, but also we had an interview halfway through. There were 66 adaptive Irish céilí dance sessions, which I will speak about now, and which probably gave me some of the best fun I've ever had in my life. So just the céilí dance sessions, first of all, and my mother would be laughing at me, I had to attend dance lessons, so I should have listened to her all those years ago. And again, I was very lucky with Carmel and the Munster Academy of Dance. They gave me the opportunity to attend dance lessons, you know, and learn the dances, and learn quite basic dances as well, you know, And I suppose we were very proactive, as in we thought ahead, and, you know, if certain dances didn't work and certain formations didn't work, and we allowed for that. And in those dance classes as well, I was lucky enough to take part, to learn, but also to facilitate classes, which was instrumental in making this a success, because the people living with dementia that were participating in the dance activities, they had varying levels of mobility and cognition, you know, and the purpose of this as well was to try and make it inclusive. And I'll always remember the first dance lesson, the dance session that we had. Shoe the Donkey was the first tune that we played, and I'll tell you a little story shortly about it. But I got everybody set up in the traditional format of it, and played music, and it just didn't work. Like I said, there was people of varying levels of mobility and cognition and knowledge of the dance, and people were, you know, it wasn't working. But like I said, thankfully, Carmel and myself, we had allowed for this, and I went straight into a circular dance style with the same tune, and that it was like a light bulb moment. It worked so well for the people living with dementia, for the care staff as well. And in this formation, everybody had linked hands, so it meant that the care staff was holding hands with two people living with dementia, and we advanced and retired to the music, and it was absolutely amazing. I think that the sense of touch for everybody, and that we were all one unit, it was excellent, and it promoted inclusion. So again, the people of varying levels of mobility and cognition were included and were part of the circle, and also people in wheelchairs were included in this, and it was absolutely amazing. And that was one form of dancing, and to finish up every dance session, we danced waltzes, and something that was amazing with the rhythm of the dance, you know, and seeing the people living with dementia just pick up the rhythm of the dance so much, you know, and there was definitely an embodied memory there, and I'd often see it at the start of a session was the ladies would sit on one side of the room and the gentlemen would sit on the other side, and it was like being transported back to a céilí. And the participation was not just dancing, you know, it could be chair dancing, clapping, and observing and just being present. So it was so inclusive and it works so well. You know, to be quite honest, it was something that I was, you know, I suppose it blew my mind really. And there was a particular gentleman who used to have to be helped off the bus, assisted off the bus in the morning, and he'd be using a walking aid. And when the music came on, he danced better than anybody, and his feet, you know, just picked back up where he was all those years ago, and it was absolutely amazing. I'll touch on it again shortly, but yes, I was just talking about before I forget it. It was Chew the Donkey, and the dance lessons. Chew the Donkey was a tune that we did every week, and I remember week 3 or 4 I walked in on the Friday, and when one of the ladies see me, she said "Chew the Donkey," and it just resonated, and you know, it was a light bulb moment for me. It was something that I always think back on. I just briefly, I've picked out 3 quotes here from the interviews. You know, there's hours of transcriptions here, but I picked out just for flavor. And the first one is from Eileen, and it's, "Oh, I danced all my life, but with that it was magic out of sea." And I suppose to elaborate on this, Eileen was very quiet person, even when we'd be speaking, and when she did speak, it was often quite difficult to make sense of the conversation. But once we started speaking about dancing, you know, this is what came out, and it was amazing. And Teresa, a participant living with dementia, when we spoke about dancing, she said, "I can remember the first time I went to the dance hall, I made a beeline for Ladies' Choice, and I married him. I can't believe it." And the joy she had in her life, telling me about her life, it was absolutely amazing. And then from the staff participants' point of view, not even for the clients, for the staff, the managers, there was a buzz around the place that wasn't here before. And that brings me nicely onto the results of the research. So enhanced ability to reminisce for a person living with dementia. And it was absolutely amazing seeing, you know, looking at the people, observing them observing those people living with dementia, and you could actually tell by the songs that came on nearly what part of the country the person lived in. You know, if there's a Donegal song, there'll be a person from Donegal, they'll be singing the songs from Clare, from Limerick, from all around the country. The positive influence on mood and psychosocial well-being. It was, you know, from speaking with the care staff and from observing those living with dementia, it was something that they spoke about all week on the lead up to it. It was on a Friday, we'd have it, and when the activity was over, the mood in the care centre was through the roof, and it was something that was so worthwhile. The dance activity provided an opportunity for participants living with dementia to take part in exercise that they usually would not have, and as well, this research provided. It gave ability to strengthen bonds between care staff and people living with dementia. So when it changed the care roles. Often the people living with dementia were teaching the care staff the correct moves and how to dance. So it was absolutely amazing. So the recommendations coming out of this is like ongoing dementia-specific training should be mandatory for all staff providing care in all settings for people living with dementia, and there should be an emphasis on person-centered care for staff in this training. Art-based training should be encouraged and made available for all disciplines training in dementia care. And for example, the introduction of a special purpose award program at 3rd level, specialized dementia training for dance instructors who may wish to implement this dance program for a variety of dementia services should also be developed and encouraged. Again, the introduction of a special purpose award at 3rd level. The adaptive céilí dance program could be utilised to better inform person-centered care plans, therefore providing and maintaining a better quality of life for the individual and their family. And what I learned so much about this is the life story of the person living with dementia is so important to listen to and to learn from. And finally, more research should be undertaken to explore the psychosocial effects of the introduction of an adaptive céilí dance group activity for people living with dementia and their care staff. Like these results highlighted in this research provide a possible framework for further exploration in this area. And just to finish up, my experience when I was 23 or 24 and my lived experience of caring with my mother, like I just want to tip my hat and just say that she's my inspiration behind this, you know, and that's my mother, baby. an inspiration behind my life. And the photo in the top right is a photo that I found not so long ago of her, in my earliest photo of her in her dancing outfit. So it's, what I'm doing is inspired by my mother, but also from all those other people living with dementia and their carers who I've encountered, and I have been lucky enough to be in the position to maybe help them in some small way. So thank you very much, and I welcome any questions or feedback. Thank you.
Thanks very much, Seán Dónal. And there's a comment that just came in here, which I think sums up your presentation. Very insightful and inspiring. I can't but think how lucky those families are to have you as a dementia advisor. Yes, absolutely. And thank you for sharing your very touching personal story, because it's not an easy thing to do on a platform like this. But I know you've spoken before about your mother, and it always comes across so powerful, I suppose. And you know, to be able to share, you know, that personal story, and you were very open about, you know, the emotions, you know, the complex emotions that people go through. So I can only imagine that's hugely beneficial in your role as a dementia advisor. You know, you've walked in people's shoes, and also I was just thinking when you were presenting there on your research, which I hadn't heard about that project before, but it sounds like you had great fun doing a master's, which not everyone is able to say, but it sounds amazing.
This was fun. The writing not so much.
Yeah, I was just thinking that. Yeah, the actual dancing bit must have been good fun. But somebody said there, I'll just go back up to their comment. Music and movement can really be so powerful as a tool in the carer's toolbox to stimulate and relax, promote reminiscence. Had so many great sessions at our memory cafes. That's someone from the Alzheimer Society of Ireland talking about using music and movement in the memory cafes. So is it used much from your experience, Seán Dónal?
It is used, but in a sporadic way, you know, and I suppose what I haven't touched on there are some of the findings of research as well. It's often dependent on staff availability, you know, so I would be suggesting somebody from the outside coming in, you know, that would make it part of their role, you know, and that would be their specific role, because, you know, you've staff on, staff off, changeover. So while it's used, it's sporadically used. When I went in, it was every Friday, and it was set in stone, and it was a given, you know, and it was always happening, and it just worked so well.
Yeah, great. And someone was looking for your contact details, so we'll get in touch with that person and share your contact details. And someone else just made the comment there about activity centres are mostly closed now, unfortunately. I mean, that's the awful thing about all the restrictions that we have at the moment. And
slowly things are starting to open up, Carol, you know, slowly. And daycare centres are slowly going, but they're being cautious and understandably slow. So, and I understand where the frustration would be around this, but even this dance activity can be used in the home. You know, it's so, like, you don't have to be a good dancer. You know, throughout the research, I was the worst dancer out of the group, you know, so you don't have to be a good dancer. It's about, you know, taking part. Yeah,
absolutely. So there were three very, very different and very interesting presentations. I think, you know, we heard about the clinical practice side of things from Professor Brian Lawlor. And then Professor Michael Rowan was talking about, I suppose, getting under the bonnet and the nuts and bolts of what's going on in the brain. I think that was explained really clearly. And then Seán Dónal O'Shea finishing up with the kind of social research, if you like, and looking at céilí dancing, and then also life as a carer and you know, supports that are available as well from the Alzheimer Society of Ireland and other organisations. So I'm just looking at some comments coming through there. So there's a question for Brian. How can the issue of deprescribing be efficiently addressed? The hospital consultant has the appropriate knowledge and authority to do this normally.
So I think that a lot of work needs to be done in this area. It's not that easy, because sometimes there are multiple prescribers, and it's not joined up. And I think we probably need to work with local pharmacies, pharmacists, and all the prescribers. I think there's a lack of awareness out there about this issue, and there's an assistance problem as well. In some countries, they have introduced mandatory pharmacy reviews for people with with dementia and older people. And I think that's an interesting approach. And I mean, and I'm aware of one study where they're looking to see whether that type of pharmacy review, whether it actually impacts on the outcome for people with dementia. So we may need to think about things like that. So as I say, I think NILVAD secondary analysis kind of highlights the issue and the problem. And I think we need to look together at solutions. I'd be curious to see what people like Dónal and other dementia advisors think about this, because I think it's about, we need to put our heads together and talk to people with dementia, caregivers, dementia advisors, in terms of coming up with a system and approach. Could I just say just about the Irish dancing? I think it's kind of wonderful to hear this. I mean, I'm not sure that Dónal knows about Rachel Hegarty. I mean, she just released a book of poems recently. She's in here at Trinity, at Trinity, and she's at the TAP program. But there's poems about her mother. Her mother was a secret dancer, and then she kind of was a way that she was able to relate to her mother. All of these poems kind of reflect on the dancing metaphor, and it just reminded me about your own mother, who was a dance teacher, but also the power of the research. I mean, I think you're not just talking about, you're not telling a story. You now have shown how research validates really what we know works. And it's really hugely important part. The role of arts and creativity for dementia, and arts for dementia, social prescribing in this area. And again, that's happening now, but we need to get arts for dementia and social prescribing there. And again, as you're saying, Carl, it's kind of it's interesting to see the different range of research. From Mike's basic research. Mike has been doing this research for such a long time, and all the way through to clinical, now into implementation and what's happening with people. And to show that range of DRNI, I think it's great to be on a panel like this, where we're breaking down these silos and able to have these communication conversations together, rather than just in an echo chamber talking to ourselves, because it's all relevant right across the continuum. It's all relevant.
Yeah, absolutely. And as you say, the idea of our research network is to get different disciplines together, like we're doing this morning, to talk about the basic science, the clinical research, clinical practice, and social research. There's a comment came in here, very interesting presentations, and a moving one from Seán, thank you. There's been some recent research on the benefits of light therapy and sound therapy to stimulate gamma waves in the brain. I think the idea being that this stimulates the brain to clean up these plaques in the brain. Just wondering whether the presenters have any thoughts on this area of potential treatment. I don't know if anyone's come across that.
We have been carrying out some preliminary research in our models showing that, in fact, this is quite a promising approach, and it may not just be at the level of clearing the proteins, may actually target the actual effects of the proteins as well. So as you can imagine, once the synapses start working together, they need to talk to each other in a sensible way. And certain oscillations in the brain, some of which are called gamma, which are up in very high frequencies by the brain standard of oscillations. The standard gamma frequency is about 40 cycles per second. So if you present sensory stimulation at this range, it can maybe engage the brain and get the oscillations activated again, because there is some evidence that in Alzheimer's disease, these oscillations start to get out of function, and maybe by providing sensory stimulation, whether or not it relates to the phenomena that Seán is talking about, where you get motor engagement as well. Maybe, a whole host of sensory inputs are certainly essential for maintaining good health, and hopefully might have some benefit in Alzheimer's disease. But the clinical trials are just early at this stage, but it's a relatively safe approach, it would seem. The main possible issue might be compliance, where the standard therapy is for at least an hour, where you'd be sitting, listening and looking at certain stimuli.
Okay, great. Thank you, Michael. So I was just trying to move on my slides here, but my computer isn't playing ball with me. So.
I'll just pick up slightly and just something slightly that Brian was touching on as well, and its importance of talking about dementia, and this format is excellent. And I think Ireland, even in the last 10 or 15 years, we have progressed so well. We've come a long way, a lot more to go. But it's getting out there and having that conversation around dementia, you know, reducing the stigma around it for like family care, but for the person living with dementia. And like I said earlier, I'm a dementia advisor. This time last year, there was 8 in Ireland, and by the end of the year, we'll have 28, you know, so there's a recognition at a more senior level of the need for dementia advisors around the country. And again, if people are looking for information, Alzheimer's.ie, and you'll find a dementia advisor in your area and link in, you know, it might just be the phone call that could help.
Absolutely, and we'll finish on that note. So I've just put up some resources there, as Seán Dónal mentioned, about the Alzheimer Society of Ireland, and they have a website and a national helpline. We also have Understand Together, which is a public campaign led by the HSE, and Dementia Pathways for Healthcare Professionals. So I'd just like to finish by thanking our speakers, Professor Brian Lawlor, Professor Michael Rowan, and Seán Dónal O'Shea, for some really interesting presentations. As I said earlier, the presentations will be up on our YouTube channel by the end of the week, and the copies of the presentations will be on our website, dementianetwork.ie. And thank you to everybody for joining us this morning, and for asking the questions and making some comments as we went along. It was great turnout. And our next webinar will be on the 29th of November, which is a Monday, and it'll be at 11 o'clock again. And that will be on frontotemporal dementia. So hopefully you can join us for that. And the booking is the same through Eventbrite, the same link. And we'll be using the same Zoom webinar link that day as well. So thanks everybody, and have a good day. Bye now.
Thank you.